You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network. Welcome to Pharmacist-Prescribed, a series about the expanding role of community pharmacists in patient care. In today's episode, More Than Meds, we explore the mission behind PRISM and how pharmacists can close critical gaps in healthcare access.
Hey, welcome, Pharmacy Podcast Network listeners. Special series today, and this is all dedicated to our pharmacists out there. Shout out to Tamara Rugels, who's out there consulting and working for long-term care pharmacies throughout the country. I thought of you when we were building this series, Pharmacist-Prescribed podcast series, and we have some special guests today, people that I've learn to trust in driving technology to be put in the hands of our pharmacists with the evolution and the changes happening. We're getting away from the dispensing fee. We're going to start getting deeper into treatment tracking and treatment notes sharing and being able to do more with that data. I would like to welcome Dr. Devin Bustin and Mary Kucek to the show. It's so good to see both of you.
Thank you so much. We're excited to be here.
Thanks for having us.
All right, Devin, you're up first. Want to introduce yourself to the listeners and just give a short background before we get into today's episode. And today's episode is More Than Meds, and this is the mission behind PRISM.
Yeah, no, thank you so much for having us. I'm Devin Bustin. I'm an emergency medicine physician with a decade of experience clinically, and I also do clinical informatics as well. And I got to partner up here with Mary to build out what we're going to be talking about today. So very excited to be here and, huge ally for pharmacists and just really excited to kind of be part of the revolution.
Mary, I am proud of you as a father of 4 daughters who I want to empower. I want to make them feel safe in such a crazy world. I want to infuse them with the passion to look and to push and to keep going with knowledge and backing themselves with evidence and with proof. And so I've talked about you to my own wife, and I introduce yourself to our listeners.
Thank you so much. My name is Mary Kucek, and I'm the founder and CEO of Ovariate, which was the company behind the PRISM application that we are talking about today. And I have over 15 years of experience in technology that's been mostly focused around health and science IT. So I've been working with departments of health and departments of agriculture. So it's been a joy, and we're really proud that we've been able to acquire NIH grant funding to really push the PRISM application to life and to make sure that we're doing everything evidence-based and science-based and working with the pharmacists on the ground to get them exactly what they need. So we're excited to be here and excited to share about it.
We're excited to hear about it. And listeners, just in case you might be jogging or running around or doing something where your hands are not free, don't worry about it. In the show notes, there's going to be a link, and it's going to be to the website that I want you to reach out and explore. And that website is getprismrx.com. Once again, that's getprismrx.com. Today, we're going to be talking about that mission. You know, it's more than meds. We know that. This is a mission behind PRISM. We know that treatment and tracking and being able to make money as a provider and as a specialist, digging down into de-prescribing or a disease state management, if you don't have a system to do that, if you don't have a system to connect that to billing abilities and getting into incident to billing and someday not having to have necessarily incident to billing, but then also collaborating with physicians like Devin, then we can't really move forward. So the mission of PRISM is in line with what's happening. And to kick this off, I just want to ask, why the name PRISM? Why is addressing healthcare deserts and reproductive access and the underutilization of pharmacists? Why is that important to you guys?
Yeah, I'll answer the PRISM, why PRISM question. So we did a clinical trial. Actually, we're just finishing it up. And I don't know if you guys know, as the listeners, about the clinical trials, but man, they love acronyms, don't they? So, we developed a modular system to help pharmacists do medical services, right? So the PRISM name stands for Pharmacist Resource and Implementing Services as Modules. But you don't have to remember that. It's just PRISM.
PRISM. Yes, I always laugh. And Devin is great at coming up with names. He came up with Ouvriet. He came up with PRISM, and he's the acronym king. I think it's just the medical training and background.
Yeah,
so
they beat that into us when we do research. So.
I will always make him repeat it just because it sounds so ridiculous.
That's why she laughed when you said that.
What I like about your name is the fact that you have multi-sources of data coming into a system that has this powerful light of knowledge and transfer. So we have all these different lights coming in. We have the red physicians and the purple data and all of these colors. And then white comes out, which is the evidence-based stuff.
The way we see it is like the white light is the patient, right? Like coming into the system, into PRISM, and then PRISM is spitting out the colors, which are your service lines that you're able to do because of the system.
I love it.
But I like both scenarios, actually. They're both beautiful.
Yeah, exactly.
I love it. All right, let's get into this. So our system's pretty messed up right now. It's a wild time to be a pharmacist, a wild time to be in healthcare. We were talking about a little bit about leadership right now and questionable things. And so when we have something like data, data is like, you don't have to mess around. You can look at the data, it's black and white. You can dig in and take analysis and obviously make better decisions. Right out of the gate, we know that nearly 80% of rural America is considered medically underserved, and over 45% of the U.S. Counties have no low-cost reproductive health center. I think that's a good way to kick this mission off. Mary, I'd like to hear from you and just some of that background and setting the stage for the creation of PRISM.
Yeah, so I mean, when we originally started with PRISM, we realized that there was an entire patient population that was completely being missed in the United States, and I know we all laugh and joke about our favorite statistic in the world, but as 90% of pharmacy, or 90% of America lives within 5 miles of a pharmacy, they're able to touch and reach these patients and actually see them. There's about a 19,000 person physician shortage right now, and that's estimated to increase to 140,000 physicians by the next decade. And so we need pharmacists to really kind of step into this role, which they've been trained upon. They just need to feel emboldened and have the correct tools to be able to do so. So when you look at, the physician shortage next to the 330 some odd thousand pharmacists, community pharmacists that are capable and trained, that can kind of fill this gap and provide that care by doing more than dispensing, you see that there's a match made in heaven here.
Yeah. And I think, it's important to note that, it has to make sense for everyone, right? And it's, we should use carrots, not sticks, right? Like, you can't say, hey, we have this gap in America and pharmacists must solve it and be heroes like they were in COVID again. We need to create a system that incentivizes pharmacists to do it because it makes sense to do it. They enjoy doing it. They have the digital infrastructure to do it. And it's creating new revenue streams that are better margins than dispensing. And it kind of gives you power back from the, pharmacy benefit managers because they don't control that part of it. So it's kind of like a power play, kind of transformation of community pharmacy. And, we think that it's super important, quite frankly, from a public health perspective, that it happen, but we need to help it happen, right? Like, there needs to be a catalyst, and that's what we're trying to help create.
There are so many people out there who I've talked to, pharmacists, that have said, hey, I wanted to start into medical school. I wanted to be a physician. Then when I started thinking about it, I didn't really want to get into the blood, or that I don't want to touch people, and I just wanted to maybe be a scientist but still help people. And the pathway of being a pharmacist, I've heard that story many, many times. I feel the same way. I can work on an ATV and get my hands dirty that way, but certainly not human beings, for goodness sake. So I commend you, Dustin, you and your team out there that are the quarterbacks of healthcare that are pitching it out to the pharmacists.
You know what, though? It's a team sport, right? Like without the offensive line, the quarterback is not going to play well, right? and vice versa, right? You need to have someone to throw the ball to.
Right.
Oftentimes that's the pharmacist, right? But there's no reason that the pharmacist can't run a wildcat play where they take the snap and run up the middle. You know what I mean? Like, it's collaborative. It needs to be collaborative. And we have this shortage. So you would think it's pretty common sense that we need to empower all the roles to fill the gaps. But it seems like that has not really been incentivized from many organizations. He who shall not be named, the AMA. But yeah, it's interesting.
Yeah, the fact that there's going to be a national shortage of 140,000 physicians by 2036.
Yeah.
A shout out to our young scientists and chemistry students and biology students who do want to become physicians. We need you. However, in the interim, we need pharmacists to step up and to start doing medication management deep dives and treatment tracking and pivoting and like you said, making a pathway based on the original prescription and the original treatment, but be able to take a system like PRISM and run with it.
Yeah. And, with PRISM, the pharmacist is the provider, right? Like we believe pharmacists are providers, and PRISM makes it possible to do that, right? And, it's interesting because you can't just turn a switch and create more physicians, right? There's a lot of money that it takes to train physicians. It takes a lot of time, right? They have to do residency and all these things. So you're talking about like a decade, like you make a policy change right now, there's no benefit for a decade. So how do we solve this problem in the near term quickly? Well, we already have infrastructure, right? We already have pharmacies. And as Mary mentioned, 90% of the patient population is within 5 miles of a pharmacy. So that already exists. And we already have trained experts that can do this. So really, the only way to quickly address this problem is to flip the switch there and create kind of decentralized public healthcare access.
Mary, what do you think? So we have these rural areas that are now getting further and further away from healthcare, from a facility. We have pharmacies that are shutting down, thousands.
Yeah.
And now we're like, okay, we're still asking our physicians and our nurse practitioners and our pharmacists to do more with less.
Yeah.
And in-step PRISM. So talk to us about this whole situation where you have a need. The community has needs. The population, what are we at? 335 million people in America, and that's rising to 345 million, within the next 3 to 5 years. So talk to us about, the positioning of PRISM and how you see this as a way to empower our pharmacists.
Yeah. So our mission is really to allow pharmacists to practice at the very top of their license, create new revenue streams for within their pharmacy, and help patients in their community. When, I was on TikTok recently and watching APHA videos, and they were talking about, way back when the community pharmacist and pharmacy was like the cornerstone of the community, and just kind of like how it's slipped a little bit throughout the years, and has, we have massive conglomerates now, and the mom and pop shops are often, overlooked a little bit. And so we want to re-empower those mom and pop shops. We want to bring action and access back to that patient population to make those mom and pop shops back into the cornerstone that they were originally supposed to be. So, we built PRISM. So there's that, lack of a better term, bridge to allow the pharmacist and the patient to communicate effectively. PRISM allows for clinical decision support, workflow automation. There's tons of regulatory compliance that has been automated. And so it really helps the pharmacist get started easily to provide safe, efficient, effective care throughout the community. And so we believe that, allowing these types of services is going to transform not only the communities of, and the community focus and access points, but it's really going to bring that soul back to pharmacists and pharmacy rather than just, they're going to dispense my meds. Yep. It's now creating that relationship that has been so important, where pharmacists are the most trusted healthcare providers, right? And they've retained that, but I think that this positions them in such a way where no one's going to want to leave their pharmacist.
Yeah.
When I have to move or anything, I'm like, oh no, I have to leave my doctor, right? I don't want to have to leave my doctor usually, because they're the ones that provide me that care that I need. And they know everything about me.
Exactly.
And so with pharmacists taking on this role of being able to provide these clinical services, it's not so much as a transactional role as a relationship and back into the community role again. And so it really repurposes, reframes, reshifts the narratives, even with that consumer-patient interaction, where it's like, that's my person. Yep. I never want to leave them. It doesn't matter if I'm also picking up my prescription from them. It removes that kind of transaction viewpoint and makes it more of that community-based relationship. So PRISM is just the tool to really help bring that straightforward and get the pharmacists back into the communities.
Yeah, and I think it makes like that change from transactional to relational, like that is how you fight against the large chains.
Exactly.
Like they're not going to be able to do that. It's just not really feasible. They didn't even try, right? They instead of empowering pharmacists to do this stuff, they hired physicians, right? Like they made it very clear. But by doing this in the 20,000 plus independent pharmacies in the US, we're actually decentralizing public health care to address the current access and spending crisis that we have. And then we're actually shifting clinical service revenue from large healthcare corporations to small local businesses. So I just can't imagine like a more American thing than supporting your local small business and kind of fighting the oligarchy that we have in this country right now. And so we're talking about like, this is a healthcare revolution. Like we want to change the way that patients think of the system and where they go first. We think that for non-emergent healthcare services should be their community pharmacy.
As it once was.
As it once was, exactly. And as it is in many other countries still to this day.
Yeah.
So out of the 337,000 community pharmacists throughout the country who are trained and capable of providing such care, talk to us about the simplicity of the system. Pretend that I'm a pharmacist and I want to implement PRISM. Talk to me about getting started, and then things like the financial ability that it provides, the essential health services that you're tracking, and then where to go from here from a perspective of next steps for a PRISM implementation.
Yeah, so I mean, first step is to reach out to us, get a demo. We're happy to speak with anyone, single pharmacy owners, multi-pharmacy owners, small chains, grocery-based, et cetera. Like we're built for all of you. But let's think of it like starting with the beginning of the pathway, right? So first and foremost, it creates a digital scheduling and kind of entryway to your pharmacy. So the patient creates a profile, they find your pharmacy, or they scan a QR code in your store and, book an appointment same day or like walk in with your pharmacy. And they create an account with the typical stuff that you'd expect, right? The typical demographics, insurance, et cetera. And then they pick a service, so let's go with contraceptives. For contraceptives, each state actually has different rules in terms of like what form they have to fill out and what the outputs are. So that M in PRISM modular is that we have created an EHR, an electronic health record system, that compensates for what state you're in and what service you're providing to make sure that the patient fills out the right form, that the algorithm is the one that the state says you need to do, so that you remain compliant, and that the outputs are automated when you sign the note, so that if you get audited, you don't have to really worry about it. So the patient enters this information. To your point, Todd, you said, data it kind of makes everything possible, and that's 100% true. But what's the best type of data? Data that you didn't enter yourself, right? Because data entry takes time and it's inefficient. And so the patient enters the data for you, creates an appointment, it shows up on your portal, they show up, you go into their encounter, or you can check out their chart, you can see all of their medical history and whatnot in the chart. But you go into the encounter and your SOAP note is already done for you. Like, there's zero typing there. You have a SOAP note that you would be proud to show an OBGYN. They would say, wow, like, this pharmacist really knows what they're doing, which is awesome. And then when it comes time, you can make edits very easily. When it comes time to pick a medication, we have 3 categories. We have something called qualified. That means you are allowed to prescribe this medication for this patient based on the protocol. We have something called insights, which takes it a step further. Hey, you could prescribe this one, but maybe don't, because they used a similar one with an active pharmaceutical ingredient and they had a bad response to it. They were vomiting too much or whatever it may be. So you don't have to memorize now all of the other contraceptives that have the same pharmaceutical ingredients. We will filter that out for you. Or vice versa. They had a great experience. Okay, well, why don't we stick to a similar one? Maybe that one's off the market, but maybe there's one that replaced it. So we help you with that, called Insights. And also we learned through our feasibility study that pharmacists want to know why they shouldn't do something. So in there, we have real-time educational feedback. Hey, this patient has, migraine with aura. They're not qualified for estrogen. And you say, well, I wanted to prescribe Junel. Well, you search Junel and you hover over it and it says, you can't prescribe Junel because it has estrogen and the patient doesn't qualify for that. And it's against the protocol, right? So that decreases liability, increases confidence, right? Increases patient safety. And, it makes it a lot easier to get started. Like, pharmacists know a lot, and with a little bit of, clinical guardrails there, they're really ready to go. We're seeing it in our current clinical trial. I can't discuss the results yet because we're going to publish it, but they're crushing it, absolutely crushing it. And then once you pick your med, we're SureScripts certified for electronic prescribing. Did I say that right?
Okay. For new prescriptions.
For new prescriptions, SureScripts has like legal verbiage you're supposed to say exactly, but essentially this integrates our system to the existing workflows. You prescribe it electronically to yourself automatically. It goes into your pharmacy management system and you dispense it like you normally would. There's no interruption in your workflow there. It's just fully integrated.
And it reduces the data entry, right? You're not moving between one system and then having to repeat it into another system, which is where I would say 99.9% of the solutions are to date, is you're filling it in one location and then, okay, let me also put it into my PMS. Okay. Right. Oh, let me scan this.
Patchwork.
Okay. And so, the patchwork we got rid of it.
It's inefficient, right? Like you asked earlier, Todd, actually, you said, well, they're already very busy. Pharmacies are already very busy. Totally. Absolutely. That's why we created PRISM, not because we're trying to add more to your plate, because we're trying to make it so efficient that you can do this without it causing disruptions.
Yeah, there's a common landscape that's happening to all of our healthcare providers in different systems, as well as shutting down private hospitals and big business buying up more hospitals and putting this into insurance systems. And it's not good healthcare from a business scalable perspective. It's crushing the private owners. So this is the tipping point. This is the current landscape. Talk to us a little bit about that and what this means for listeners, as well as pharmacists who are concerned with fertility and management of that and contraception for their patients, and the ability to take advantage of a system like PRISM.
Wow. I think I'll take this one, being the contraception. No, everything you just stated is extremely unfortunate. And with the loss of Title X funding and CMS reimbursement uncertainty right now, there's a lot of women that are facing this reality of, can I even get my contraception at my normal location? If not, where do I go? How do I afford it? And so Planned Parenthood, regardless of anybody's political beliefs or opinions of Planned Parenthood, they issue over 2 million prescriptions for contraception annually. And with many of these programs either closing or no longer allowing for that funding to occur for contraception or STI prevention testing or anything else, realistically,
cervical cancer screening,
all of it, we're going to see a lot of patient displacements. And this is where I look at it and go, this is horribly unfortunate, but the pharmacists in our local communities can really take up this role.
Yeah.
And
it's opportunity.
Just like, you know, when COVID occurred and pharmacists stepped up before, I hate to say this is women's version of, but we are about to be on the precipice of 2 million women not obtaining access to contraception affordably in the United States. So 60% of the clinics and Planned Parenthoods they're either in the process of closing or may close, and they're already in underserved areas. So that's a huge and unfortunate stat that needs to be filled. And I think that our local pharmacists can really take it on.
And, you know, like the demand for contraception is stable, right? Or increasing. It's not going down. But now the access is going down dramatically, unfortunately, and we're losing our safety net. So just basic economics there, right? Like that creates an opportunity. I hate to say it like that because it's a tragedy, right? But, you know, someone has to fill that gap, and it might as well be a small business pharmacy that, you know, stays in business because they can do that. And then that creates additional value to their community. But, you know, you got to think of like each of these closures, you know, Mary mentioned a bunch of kind of big numbers, right? But let's think about it from like each person's perspective. So, you know, you remove this critical access point, right? That may be the only one in the area for many people, right? And now all of a sudden you can't get contraception, STI testing, cancer screenings. Well, that actually decreases, like that makes outcomes worse. So there's morbidity and mortality. We know that in places with decreased access, you know, maternal morbidity goes up and mortality, right? So like there's a real human life cost to this problem. The other thing is, even if they don't close, right, a lot of people are relying on publicly funded assistance, right? So the Title X that Mary mentioned, you know, Medicaid, if they lose Medicaid. So now they may have to pay higher out-of-pocket rates. So even if the safety net facility exists, it becomes unaffordable to them all of a sudden. So there's a lot of barriers that we got to think about. We got to think about like how far of travel, right? What if you're a single mom, you have 2 jobs? Well, probably the last thing a single mom needs that doesn't want to have another child is an unintended pregnancy. That's economically devastating, right? Yeah. But how are they going to go 50 miles when they have 2 jobs and a kid to go get access to care? And, you know, we didn't mention this earlier, but the average physician appointment in metropolitan areas is 38 days out. So that's kind of far. And it's been getting worse every year over year, every time they do the survey. And that's just metropolitan areas. So rural areas, we already know, is significantly worse than that. And so this is going to lead to delayed care. It's going to lead to unintended pregnancy, cervical cancers that could have been prevented, maternal morbidity and mortality. And, you know, a lot of this can be prevented through, you know, empowering pharmacists to step in and do it in a profitable way that makes sense for them. And then the other thing is like, okay, well, are patients ready to go to pharmacies for clinical services, right? Because there needs to be a customer base. Well, the national surveys that have come out are fairly clear, yes. Most patients said that they would go to a pharmacy first for non-emergent services, that they would actually prefer that. And 81% stated that they trusted pharmacists to provide that care. And then in studies specifically about pharmacist-prescribed contraception, about 2/3 intended to go to a pharmacy to get a contraceptive service. So if they know about it, they're super interested because it's more convenient. You know, there's those trusted relationships that Mary mentioned. Some people don't have a regular physician. Walk-ins are available, extended hours, you know, et cetera. There's just so many things that, you know, the pharmacy infrastructure decreases barriers for patients.
And I think a lot of patients actually want to see a provider, right? Like there's always going to be a place for telehealth. There's always going to be a place where that type of relationship makes sense, but it doesn't always.
It's not for everyone.
I would have loved to go into a pharmacist, to go pick up a prescription. And I even do outreach, like patient outreach for some of our clinical trial participants. Yeah. And when I'm calling patients and when I'm talking to people like on their store, like in the storefront, they're super excited to hear about what we're doing. And some people are signing up because they're like, I believe in this so much. I just want to be on the cutting edge science of it. Like, it's really cute to see patients that are just like, I want to do this for women. Like, we're in it to win it at this point. So,
a lot of enthusiasm.
There's so much enthusiasm also from the patients that you might not have anticipated. And it's because they're actually feeling empowered and they're actually starting to feel like they're finally getting clinically served in their communities, rather than going to the back of the line and waiting 40 days to talk to somebody for 3 minutes, right? Like that's the frustration of just, the patient population right now, specifically with women's health and contraception.
The patient experience for in-person healthcare is dismal. Right? Like, think about it. We used to wait in a lot of lines, right? And lines have gone away with technology for most things. Even the bank, right? You used to have to go wait in a line in the bank. Now you just go to the ATM. You can do whatever you want from the ATM. That has not translated to healthcare. And telehealth came in and said, hey, like, we'll make it convenient. But they just lifted and shifted traditional healthcare models. So the people who didn't have access still didn't have access. When you look at telehealth as a modality to increase access, what we find is that it increases access for those who already have access.
Already insured. Yeah.
So like that, that's important. It's nice to have choice. I think, that's Americanism, like capitalism, right?
Yeah,
like,
convenience at its finest.
Let the patient decide, right? But a lot of these telehealth companies have kind of gone the e-commerce route. It's really I would call it no longer medicine. So patients want to see someone they trust. They don't want some doctor behind the scenes that you don't even know their name clicking a button to approve your prescription that was generated by a computer, right? Like, they want to talk to somebody, but there's not a really great way to do that unless you want to spend a lot of money on a concierge provider.
Yeah, there's another element to this, and that is that PRISM, its fundamentals, its technology, it aligns with our pharmacists moving towards national provider status. And we know that provider status is available in different states throughout the country, obviously, like California, but it's the 37 states that are saying, hey, you are a provider, you're going to be able to do things like prescribed contraception and other things that, test to treat and PrEP and PEP and tobacco cessation. That's wonderful. And that's tied into the evolution of this. But talk to us about that alignment and what that means for the future of healthcare and accessing healthcare.
Yeah, so the barrier isn't primarily the pharmacist scope anymore. We're starting to see kind of the ball move a little bit further, which is great. But there's a lag on everything else, right? We're starting to see pharmacists slowly get to provider status ever so slightly, but that means there needs to be a digital infrastructure, reimbursement pathways, the fact that, there's lack of workflow support. They're expected to wear every hat without any real technological help still. It's overwhelming. So there needs to be solutions to repair these gaps. And, the traditional pharmacy management systems, they're built for dispensing and they're great, but it's not necessarily been built for direct patient care. Yeah. And so it still leads to scanning and faxing and manual documentation and patchworking of multiple systems, kind of like what we talked about earlier. By the end of it, you're paying like $500 to $1,000 a month to
they don't even
to Frankenstein your systems in a way that's still HIPAA compliant, because you still have to follow all the compliance guidelines, right? So there's so many obstacles still in the path for pharmacists that even once full provider status is established, there's still a number of things that can kind of hinder. And that's really what we're trying to make sure that we alleviate there.
Yeah. And I mean, we look at, you mentioned, the movement of provider status and, the ECAPS Act right now, bipartisan support, has a pretty good chance of passing is what I'm being told. That's so important, right? So like that would allow pharmacists to bill Medicare Part B for the first time ever. And you think about like, what doors does that unlock? Mm-hmm. Lots of doors. So I would almost say this, you want to be already providing services before that gets passed, right? Because when it does, the floodgates open and you have a running start.
Yeah.
Yep. All right. I want to go through some of the functions for our listeners of this amazing platform. It's a pharmacist-specific electronic health record and workflow platform to solve specific challenges. Kind of list, maybe you take turns kind of going down through a list that we've come up with to share with our listeners. It's going to be in the show notes, by the way, so that you can reach out to the team at getprismrx.com. But take us through these.
Yeah. So I mean, from like a theme perspective, now you have a digital doorway that you might not have, you didn't otherwise have that.
The patient portal.
Right.
You have a patient portal that includes multi-factor authentication and has all the security guidelines that are absolutely required. It automatically posts all of the medical information that you are required to provide to a patient.
Yep.
Right. So a lot of the states say you have, this is particularly with contraception, like you have to prove that you also, counseled or at least provided information about IUDs. As soon as you prescribe a medication, IUDs is right there.
It's in the patient
education forms. And that's also available to the patient in their patient portal, but it also posts to the pharmacist portal so they can prove for any audit checks that they've done everything.
Yeah.
Right. So there's this two-headed approach of like, oh, look at this nice thing, patient portal. And we did all the regulation behind it, so you don't have to worry about it. And that's kind of the common themes that we've done.
Yeah, I mean, you think about like, I don't know any of the listeners if you've started doing contraceptive services already, but if you have, it's probably on the paper forms that your board of pharmacy requires, right? And you can't do anything else with it. You have to scan it, fax it, or whatever, scan it into your system just for documentation repository, or file it in a cabinet or something and keep it for 7 years. Well, we've digitized all that, and some states still want you to have that form. So we recreate it for you, right? Like we've thought of everything from an audit perspective.
If a state requires that form to be complete, the patient can interact on their pharmacy portal with it's the same questions, it's the same everything, but it's a little bit friendlier viewpoint, right? It's dynamic. So that automatically pre-populates all of the information in that state form. So the state form still shows up. It's still there. You're still following complete compliance, but the patient didn't have to sit there and do a paper form. Yeah.
And then on top of that, now you have your SOAP note done, right? Like that form is worthless for communicating with other providers. I want to make that extremely clear. If someone faxed me that form as a physician, I'd be like, what the hell is this? Right? So the SOAP note that we create for you is like, that's real medical documentation, not just some checkboxy form. Like checkboxy form is like, that's crazy, right? So now you have the SOAP note. Now you have care coordination ability, right? When you prescribe something, a lot of states say, you need to notify their primary care physician. Well, we already collected that information and we automate for you the notification form. If an auditor says, did you notify their primary care? Yeah, look, right here. Here's the form that we did, right? So again, we've thought of all of those aspects. We also allow for referrals. I mean, some people may come in and not be a good candidate for what they want, and maybe they do need an IUD or a long-acting reversible contraceptive. Well, we allow you to have pre-saved referral outlets. So you can just click like, Dr. Johnson down the street, and then patient needs IUD in the comment. And all of a sudden now you have like a referral document that you can send to Dr. Johnson so that he'll see your patient and give her an IUD if she wants one. So, we've kind of helped with all of that care coordination aspect. We're working on billing. We're going to have billing very shortly, which is going to be helpful. That is a whole another topic of conversation. I think anyone who's gotten into services billing with insurance companies will know, but we're going to have something that's very low barrier to entry with that.
Yeah.
we mentioned the SureScripts e-prescribing. I mean, that's huge because that integrates this workflow of clinical services into your existing dispensing workflow. And then we kind of touched already on the clinical decision support, but making sure that you can't prescribe something that's going to harm the patient or get you in trouble or get your license revoked, right? And, helping you choose from the hundreds of available options to try to narrow them down to something that makes a lot of sense for the patient.
When we were first starting this process, we actually did a HIPAA compliance survey and reached out to nearly 2,000 different women who had been previously prescribed contraception.
Yeah.
And one of the qualifying questions was, have you tried multiple forms of contraception? Nearly 30% of those who had tried multiple were on the same exact medication, active pharmaceutical ingredients, with just a different name.
Yeah.
Right. So they were taking the same exact medication, going in saying, hey, this gave me a side effect of acne or breakthrough bleeding or whatever.
Yeah.
And then they were provided the same exact medication with the same active pharmaceutical ingredients, but under a different name. And so patients this is happening to patients in real life.
It happened to you, didn't it?
It's happened. I've taken the same pill over and over again, and before I knew better.
Right.
And I'm super annoyed. But to know that it wasn't just happening to me, and it's been happening, like the fact that it was nearly 30% of all of the patients that we had even done the survey to, I think that was that aha moment where it was, okay, we need to do something with this clinical decision support to make sure, because women just think that they're not good with any birth control, right? Like they'll try two. And if you gave them the same thing both times, they're just like, oh, I'm not good with any birth control. They
all give me blah, blah, blah.
Yeah, I'm just not going to take it anymore. And it's like, oh, you slipped between the cracks on a broken system and you tried the same exact thing twice and expected different results, not knowing any better.
The truth is that no physician, no OBGYN, 0% of OBGYNs, I feel very confident in this fact. 0% of OBGYNs have every contraceptive on the market memorized by the brand name and can recite what active pharmaceutical ingredients are in there. If there's no OBGYN out there to prove me wrong, I would love to do a live testing to try to prove me wrong, but I can guarantee you're going to get something wrong. And the truth is machines are better at that, right? Like it's a lot easier for us to just put that into our database structure and help empower pharmacists to avoid things that have been poorly tolerated in the past. So this is a complex problem that machines are better at solving than humans.
Well, we're excited to be supporting PRISM. I'm excited to be able to talk about more of this for you to show up on This Week in Pharmacy, but we're also going to be having Mary and Devin show up on other podcasts throughout the network where this solution and these systems fit into those subjects. And I'm going to be reaching out to Daniel Plummer and Jenna Quinn and Tamara Rugels and all these superstars that you should definitely be tied in. I want you as a pharmacist, I want you as a pharmacy owner to reach out to this team, ask lots of questions, get a hold of Mary or Devin, get a demo scheduled, go to getprismrx.com. And you'll be hearing more. This is part one of a 3-part series where we're going to be concentrating on the future of our pharmacists and the role of pharmacists expanding with Pharmacists Prescribed. This is the Pharmacist-Prescribed podcast series. Thank you both for being here and for launching this.
Thank you so
Absolutely.
much.
Thank you, Todd.